Tammy, you happy to get started? Mpumi, okay? Great, okay. Hi, everyone. Welcome to the suddenly online noon meeting for the school for this week. The meeting this week is being hosted by the Division of Epidemiology and Biostatistics. And presenting today are Tammy Phillips and Mpumelelo Zondo, who are well known to the department and the division. And they'll be presenting today on the topic of Tammy's NIHK award, so her Career Development Award, post-PhD, which is focusing on issues of choice in patients returning to care, receiving antiretroviral therapy services. And so a lot of the focus will be on discrete choice experiments, DCEs, which are super fashionable right now, which has been a major area of expertise for Tammy and Mpumi. We're looking forward to hearing the learnings from this and probably some of the broader learnings about doing DCE experiments in public health in this setting. We're really looking forward. Tammy will hand over to you for about 30 or 35 minutes, and then we'll do Q&A for the last 15. Okay, go for it.
Perfect. Thanks very much, Landon. So yeah, Landon has introduced us. Just to say up front, Mpumi has done and led a lot of this work. So I'm going to kind of give a bit of background to how we set it up and the formative work that went into the design of the stated preference surveys, and then Mpumi will present the results of the surveys, and then I'll wrap up a bit at the end with some of our planned next steps and thinking. So I'm sure for many of you, this is not new information, but we are much more comfortable now with the idea that engagement in HIV services is really not linear or unidirectional, and with our very long-term HIV cohorts, we have many people cycling in and out of care over time. And this is work from Peter Ehrenkrantz and others in CIDA have documented this in more detail for the Western Cape, which just more clearly moves away from our very linear cascades and sort of cross-sectional cascades into thinking about how things change over time. And this became an area of interest for me, specifically in terms of thinking about people reinitiating treatment. So these are data from the Western Cape, which show how over time the numbers of people in the light blue bars, the people restarting treatment, have overtaken quite dramatically the numbers of people initiating treatment for the first time. And now it stands at about 60% of people who initiate treatment in our services are actually reinitiating treatment and have some treatment experience. Also, when we compare the new starts and the restarts in terms of their outcomes, the proportion lost from the services is much the same, whether you're a new start or a restart. So we're all quite comfortable, I think, with the idea, and it's been documented in the literature, that new starts are vulnerable to being lost from HIV services in the early time on treatment, and the same holds for people reinitiating treatment. So between 30 and 35% no longer engage in ART services a year after either newly starting or restarting treatment in the and these are again data from the Western Cape. So I was interested in thinking about the various things that go on in people's lives, and really the data, the literature kind of coalesces around this idea of life is kind of complicated for people, and HIV is really just one thing that's going on in their lives. And there's this really nice systematic review from Ingrid Eschen-Wilson that develop this tipping point idea of the various things that are going on for people and what might ultimately lead to why somebody disengages or re-engages with the services. But ultimately, the data from across sub-Saharan Africa and the existing data from South Africa talk about how there's this need for adaptation and incorporation of treatment into your daily life, how characteristics might need to be distinct. People might have distinct needs from the services at different points in their treatment life course. And how changing life circumstances are frequently the reason why people disengage from the services, and that our health services are not responsive enough to this complexity. And one particular aspect of that is around mobility and travel and movement between the services. So the focus of my NIH K43, which is a career development award, was thinking about how can we design an intervention to support people returning to HIV services by incorporating some aspect of choice and patient preference in the way that we design the intervention, with the hypothesis being that if we from the get-go, incorporate patient preference in the design and ideally incorporate an element of choice within the intervention itself. We will be able to empower patients to be more actively engaged in the service and perhaps improve their engagement in care. So there were three aims of my K, which is just coming to the end of year 4 of 5. The first was really to characterize the existing practices and context around return to care for ART in the Gugulethu area, and thinking about what happens currently for return to care from providers and patients. Secondly, to refine support interventions based on patient preferences. So that's the stated preference surveys, which we're going to present today. And then the third aim was to do a feasibility study to assess feasibility and acceptability of an intervention that incorporates these preferences, which we've now gathered, and incorporates a component of choice in the intervention. And that's planned for the coming year of the award, if that goes ahead. So aim 1 of the study was around the implementation context. As I said, the study is taking place in Gugulethu, where there's a very high HIV prevalence and a very large HIV program. As I said, about 60% of all people starting treatment are reinitiating with some treatment experience. So we conducted in-depth interviews with patients who'd recently returned to care at the Gugulethu Community Health Centre and at the Gugulethu Clinic. So one Provincial Department of Health run CHC and one City of Cape Town clinic in Gugulethu in 2022-2023. And that work was guided by the Consolidated Framework for Implementation Research, really thinking about the inner setting, the context within which services are delivered, and the characteristics of the individuals involved in that. One thing also to raise, which I'm sure many of you are aware of, was the Welcome Back campaign, which was a national strategy to really encourage people to re-engage with health services generally and for HIV in particular. And that was very strongly supported by ANOVA in the Gugulethu area, with dedicated Welcome Back nurses and active re-engagement of people into the services. So our work really took place from the time that somebody was back in the clinic and didn't go back to so with the IDIs with returning patients, it really just echoes the existing literature. Reasons for interruptions are complex, often overlapping, quite personal. It's very difficult to weed out one specific reason why people disengage or to find one characteristic of people who are lost from care. Consequences of the complexities of life, travel, relationships, having fun in the holiday season, personal circumstances like deaths in the family, things like that. Also some structural issues related to waiting times, and then specifically issues around requirements for documentation of transfer, either actual, like people being turned away because they didn't have transfer documentation, or anticipation of, like, I thought I was going to need this stuff and I didn't have it, and so I was afraid to go. Fear of experiencing stigma in the services. And then this idea of people wanting to feel heard and respected, and this quote just really highlighted that. They must take you, this is from a male patient, they must take you as your own family. They must tell you straight, but not be rude. And so that sort of really came out strongly in the patient data. With the providers, again, this lot of overlapping issues. So the sense of providers really being caught between being very empathetic, wanting to deliver person-centered care, having a lot of empathy and respect for their patients, but also being hugely frustrated, both with patients themselves who cycle in and out of care multiple times, but also with the conditions within which they're working, feeling disconnect within the services, fragmentation within aspects of the clinic itself, folder storage, lots of issues around mobility and clinic transfer, and the sort of work infrastructure, staffing, access to computers, and some sort of knock-on effects after COVID. So one of the things that came up was this, there's clearly a need for staff training, but after COVID, there was like a backlog because no training took place over that time. So now everybody's on training, which means we've got limited staff in the facility. And again, these interviews took place in sort of 2022, 2023. So that might have evened out a little bit now. So lots of overlapping kind of structural and personal and social factors going on with the patient interviews. So all of those data were incorporated then into our thinking about a stated preference survey, where we wanted to quantify patient preferences for adherence support interventions. And then what we ended up doing is actually separating out into two experiments, one that focused more on adherence support and counseling, and one that focused more specifically on like the attributes of models of care. And Mpumi will go through that in a bit more detail. The initial attributes and levels of the experiment came from really the existing literature review, and in particularly this paper shown here from Laura Sabine and Catherine Orrell, where they did quite extensive work with patients and providers around the existing evidence-based interventions to support people at risk of treatment failure and what people thought would be feasible to do in the Cape Town context. So we drew on that and tried to think about ways that these could potentially be tweaked or offered in different modalities. So could somebody get individual counseling but over the phone or in person or through some other method? So thinking about ways that we could tweak existing support options. And then to just really say that our intervention development, the experiment development process was far more time consuming than we could have imagined, and resulted from an iterative focus group discussion process. So stakeholder engagement, refining the initial levels and attributes, and then iterative focus group discussions with our target population of people living with HIV. We ended up focusing on people both newly and restarting treatment because they seem to both be vulnerable equally to loss after initiation. And the focus of those focus group discussions was multifaceted. So both in terms of saying, well, do we have the right elements in here, and do people understand them correctly? But also just the idea of presenting a hypothetical choice experiment translated into Xhosa in a context where there's variable educational attainment and where people may not have been presented with a sort of experiment before. So we really did a huge amount of work in terms of both refining the English language to make sure that the experiment was understandable in the way that we wanted it to be, and the attributes and levels were clear, and then translating that into Xhosa, back translating it, checking the translation again, and then checking the translation and comprehension through this focus group discussion process. So what was intended to be quite a quick turnaround ended up being like a really big investment in making sure that the attributes and levels were understood in the way that we thought they should be. So we didn't get results in the end where we were like, did people understand what we meant by this? So that ended up being a really interesting process that we're going to try and document in a little bit more detail. So yeah, I'm going to hand over to you, Mpumi, to talk a bit more about the DCE.
Okay, perfect. So yeah, like Tammy had said, there are interventions and there has been quite a bit of studies, especially also studies done here in the Western Cape, which have looked at evidence-based interventions. So one might ask, why would we then do a DCE? So although evidence-based interventions do exist, it's often not feasible for us in the services to implement a variety of services. So for this reason, tools such as discrete choice experiments can be very, very valuable. So then the next question then begs, what exactly is a discrete choice experiment, right? So a discrete choice experiment is a survey-based method used to measure preferences by presenting participants with hypothetical scenarios and asking them to choose between the alternatives with varying attributes. So on the right of the screen, you can see an example of a discrete choice experiment where here a participant has been asked to choose between two alternate healthcare facilities that are defined by a set of attributes which are fixed down the left, and each attribute has differing levels. So this kind of experiment then assumes that individuals make choices about products or services based on the actual characteristics that define them. And then using appropriate statistical methods, the data collected allows us to quantify the relative importance or desirability of each attribute. And then this data can then be used to, another thing you can also get out of the data is that it can also be used to provide information on trade-offs. So what are participants or what are clients willing to give up in order to gain something else? So it's for these reasons that, DCE surpass standard qualitative methods or standard ranking methods. And then another reason that we also found a DCE useful is because it allows us to evaluate patients' preferences before a whole lot of money is put in and these interventions are implemented, as often funding, as we know, precludes the rollout of a lot of interventions, and data is often limited on patient behavior. So the DCE allows us to establish their feelings towards products and services that also may or may not exist. And then another reason we chose to go with the discrete choice experiment is, outside of it being a quantitatively superior method for assessing patient preference when designing interventions is often a neglected element. And although it's something that's widely spoken about, when actually designing interventions and using these evidence-based interventions, patient preference is not taken under consideration. So it's for all these reasons that we felt fit to use a discrete choice experiment as our preferred method. And then just to reiterate what Tammy had said, was that the main objective for the study was to design 2 DCEs to elicit patient preferences. So the first DCE focused on adherence and what support services people would prefer that they feel would help them adhere to their treatment. And the second DCE focused on models of HIV care. So that refers to how people actually receive the care and their preferences for the ways in which they receive their care. So our methodology consisted of 4 parts. The first part, Tammy did speak a little bit to, which was the selection of the attributes and the levels for the DCE. So just a bit of context, when we refer to attributes, we refer to the broader categories, such as what time is the clinic open or where you're going to get your medication. These are fixed. Then each attribute has different levels, which are the specific conditions within the category. So for example, where you get your medication, the levels would consist of, you can either get it at the clinic, through an adherence club, or an e-locker. Then when a person makes a choice, the attributes are fixed for each choice set. And because ours was a binary choice set, people only ever saw 2 levels at one time. So for example, where you get your medication in one choice set, the options may be between the clinic and an e-locker, and in another choice set, the options may be between an e-locker and an adherence club. As also mentioned, we did a vigorous literature search. We also focused on context-specific literature, and that's where we had selected our initial levels and attributes. We then did ranking surveys with stakeholders to then get them to rank the importance of the attributes and levels. And following this, we conducted 3 iterative focus groups with our target population. And this was to ensure that the items that we selected were relevant as well as comprehensible. Once we had our final list of attributes and levels, we then went on to design the actual discrete choice experiment. So we used a specially designed software for discrete choice experiments called Engine, and it is in Engine where we were able to implement what is called a D-efficient design. So what is a D-efficient design? So as you know, you've got attributes and levels. However, it's impossible to ask every single combination of choices. The amount of permutations runs up to hundreds of thousands. Thus, it's really important to pick a set of choice sets that'll extract the most amount of information. So with a D-efficient design, it aims to design a DCE such that each option is tested fairly. This means that no option is repeated too little or too much. It also helps to make sure that the questions are balanced. So when we say the questions are balanced, we mean that each option appears in a way that it allows you to compare them properly. So for example, you will never have an option that has a rude healthcare worker, long waiting times, and a far travel distance compared to a choice where the healthcare worker is pleasant, the waiting time is short, and the clinic is next door. As these are not fair choices. So the aim of a D-efficient design is to get the most amount of information from the fewest number of choice sets. We then decided to choose 36 choice sets. So that means that we generated 36 choices and we divided them into 6 blocks for both DCEs. So for both discrete choice experiments, we generated 36 choices and divided them up into 6. So that means for each DCE, each person was offered 6 choices. And in total, they made 12 choices. So 6 choices pertain to adherence support, 6 choices pertained to models of HIV care. We then, once we had designed this experiment, we then recruited our patients from Gugulethu Clinic as well as the Gugulethu Community Health Center. After this, we then initially ran a pilot where we assessed for comprehension by assessing for bias. So one of the ways you can look for bias is through understanding. You're able to tell if people are consistently selecting maybe the right side. And this can then tell you that either people are not understanding or they are fatigued and are selecting just for the sake of completion. Once we completed our pilot, like Tammy said, we put a lot of effort into our formative work to make sure that the cognitive load was not too much. So when we ran our pilot, we found no issues with comprehension, as well as we found no issues with bias. And based on that, we refined the levels of our DCE and then conducted the main experiment. So after refining, we then conducted our main DCE from June through to November 2024. The DCEs were part of a larger cross-sectional survey that had other demographics of interest. In total, we were able to recruit 330 adults over the age of 18 living with HIV who had either newly started ART in the last 6 months or were returning to care in the last 6 months after they had been out of care for more than 3 months. Then on the next slide, you can see a final look at our attributes and levels that were chosen for the study. Once we completed the study, next slide, please. We then went on to do statistical analysis. So we used a package called Apollo in the R software that was designed by Hess et al. And this is a package that was designed to analyze discrete choice data. We chose to use a mixed effects logit model. So the model is used to estimate the probability of a patient making one choice over another choice. And the covariates of the model are made up of the attribute levels. We are not so interested in understanding the probability of making the choice. However, we're interested in understanding the covariates and which ones contribute most to a person making a certain choice. We then exponentiated the estimates and presented the relative preference for each attribute level as an odds ratio. We did this for the overall population, as well as we were interested in understanding if differences by gender also existed. To then account for differences in preferences between people, we included random effects on all the covariates, and the estimates for the random effects were also exponentiated and presented as standard deviations, which were able to quantify the magnitude of the variation in preferences. Our results can be seen on the next slide. So you can see from our demographic results that we had quite a middle-aged population. There was not much difference between the men and the women, and they tended to be quite older, into their early 40s. As is sad about this population, quite a lot of people had not completed high school, so this has gone beyond grade 12, and it's also characterized by high unemployment status. And we can also see that amongst the starts and restarts, you had about a 70-30 split overall and across the genders. So these demographic findings align pretty well and are tell us that we are representative of the sample of people that we're trying to look at. Then on the next slide, we can see the results from the first discrete choice experiment, the adherence. So in the adherence discrete choice experiment, we see that clinic appointment reminders, so that's the first red box, came out as a strong indicator or a strong driver of choice. And you can see that it was a strong driver of choice in the overall cohort, as well as when interacted with gender, and it's a strong predictor for both men and women. What was interesting was that you can see that in terms of group support, when looked at overall, group support doesn't appear as significant. However, when we interacted by gender, we found that women, no matter the type of group support, preferred some form of group support. So either it was in-person relative to no group support, or virtual relative to no group support. And then we can see with men, they're skewed to the left, and the findings were not significant, and they did not care for group support. So that was quite cool to see some differences in preference by gender. Then we have the results for the model of care discrete choice experiment. And in the model of care discrete choice experiment, the biggest driver of choice, or the attribute that came out in front, was integrated health services. And again, like with the two-way reminder or the clinic appointment reminders, overall and when interacted by gender, this was something that people really, really preferred. So this was a preference for integrated services relative to standalone HIV services. So this tells us that people really do prefer to have all their appointments and all their services aligned in one. Then some limitations about our study. So as Tammy had mentioned, we only worked in Gugulethu, and we only worked in 2 sites in Gugulethu. So that will affect the generalizability of our results, as that's where our participants were limited to. And as seen in our results, our demographic was limited to an older range of adults, and we didn't have many young adults recruited, which is something we also see trying to engage young people in the services. And again, Tammy had alluded to this earlier, is that discrete choice experiments elicit hypothetical preferences. So we present people with hypothetical preferences, and we did not give them an option to opt out. So they're always forced to make a choice. And what people say hypothetically may not necessarily translate into their real and everyday life. So that is a caveat that should be taken with discrete choice experiments. Then the next slide. So now just discussing some of our findings. So our findings indicate that optimizing and effectively implementing certain services could enhance adherence and retention. So it gave us an idea of some of the services that people really, really valued. And these are some services that we are trying to look at in AIM 3. How can we optimize these such that they're being used to their full capacity? And then the observed variation in preferences suggests that a one-size-fits-all approach is inadequate. So like Tammy had said, there's a big push to differentiated models of care. And we can also see that come out in the data. We saw it quite strongly with the counseling and the difference in preferences in counseling amongst men and women. And we're also going to go on to investigate differences in age. So these results tell us that differentiated models of care should be adopted. and that, yeah, a one-size-fits-all approach is not going to work. And yeah, like we also said, we saw some differences by gender. However, there was still a lot of heterogeneity in our data, meaning that there are other factors influencing people's choices, and further work needs to be done to explore where these differences may lie. So for example, looking at age, do younger and older people want different things? And for example, do younger men or older women want different things? So that's another body of work that could be done to expand on ours to understand these sources of random heterogeneity.
Awesome. Thanks very much, Mpumi. And just to add to your discussion there, I think the heterogeneity findings, the idea is not so much that there needs to be differentiated services specifically for men or specifically for women, but rather that this heterogeneity in choices indicates that within the population, people desire different things, and we are limited in terms of our sample size, in terms of how many groups we're going to try to look at age, but we don't have that much variability. As Mpumi said, we don't have too many younger people. We're going to try to look at differences in new starts and restarts. But there is this underlying heterogeneity in what people choose, which means that even in the context of differentiated service delivery models, it might just be that people would choose different things at different times for different reasons. And so, should everybody be pushed into the same differentiated model, or can we come up with a way of saying we have multiple different tools in our toolbox, ways of offering services that people might be able to move between or choose between, is kind of the way we're thinking about it. To just give a little bit more information around our next steps. So for aim 3 is thinking about an actual intervention to pilot. And just to summarize, the issue that we're facing is that disengagement from HIV services is very common in the first year after treatment start or restart. And as we've talked about, those challenges include issues around accessing treatment history and sort of transferring between clinics, things around adaptability to mobility and changing life circumstances, difficulties with stigma within and outside of the clinic, and obviously many social and individual barriers. So we've tried to kind of map it out, and this is a little bit of a work in progress still, but to think about a logic model of the problem. What are the many determinants that are influencing this particular problem? What are the personal behavioral factors, and what are the more environmental structural factors? How do they link to the health problem of interest, which is ultimately keeping people engaged in HIV services, virologically controlled, etc. And how does that impact on their quality of life? So we're using the 6 squid steps around development of a public health intervention. And where we're landing at the moment is something around some sort of structure, like a service intervention around structure for accessing and finding treatment history. So thinking about the potential use of the single patient viewer, at least within the Western Cape, to avoid issues of people being turned away without transfer letters, and to sort of streamline and formalize the process of how one would access information, what information is actually needed for providers, particularly now with many people, both first and second line regimens being TLD. What is the minimum level of information that's needed? How can you access that? And trying to put that into an SOP, together with a low touch patient navigation intervention, some of which in the long run might be able to be automated through a chatbot or something like that. But like, what are the kinds of questions people ask? A lot of it seems to be sort of logistical. I missed my appointment. Can I reschedule? I'm out of town. How do I access? Sort of facilitating those kinds of things. And then some sort of peer support group. And the idea is to offer people a choice of whether they want to participate in a peer support model at all, and if they do, if they want to be part of an in-person group or perhaps a WhatsApp support group. And this is sort of building, we're in the process of kind of mapping out the mechanisms and thinking about the actual intervention components, also drawing on the COMBI model for behavior change. I did just want to mention some of the other data that's come out of the survey. So along with the DCE in the AIM2 survey, we asked a bunch of other questions, but one of the things we asked about was around potential interest in long-acting injectable ARVs. And so I thought I would just share that briefly. So this is 300 and it's the pilot population as well. So about 390 people. Who participated, who answered this question. They did a simple Likert scale of like, would you be interested in trying long-acting injectables after receiving information about what that would look like? And then we're asked an open-ended question of like, tell us more about why you feel that way. So broadly, there was a lot of interest. So like more than 75% of people said they were very interested, mostly around convenience, improved adherence, because it's a lot of people talked about how it will be in my system. I won't have to think about taking the meds, and how that would really create space for other thoughts and for me to focus on other priorities if I don't have to be thinking about taking my HIV treatment. In terms of the not so sure, there was a group of people who were like, I need a bit of more information, or I need to see how other people were doing on it before I decided. And then there were a group of people who were like, no, thank you. I don't like injections. I'm scared of side effects. I don't think that would be for me. And really, this just speaks to this population of people restarting and newly starting might be a population to think about for these kinds of new technologies like long-acting formulations, and also just highlights how patient perceptions and concerns really need to be considered from the outset in the way we develop these new technologies, and how we develop information around scale up and implementation when they do come to be available. And then finally, I just wanted to mention another next step. We got some supplemental funding to adapt our discrete choice experiment specifically for postpartum HIV services. And this has just gone live, finalized yesterday. And so the first step of this process is to get some input from providers who work in HIV services and maternal child health services in Cape Town on a list of potential attributes and levels around postpartum HIV services. And so if you are a provider, if you have experience working with HIV services and or maternal child health in the Cape Town area, feel free to whip out your phone and scan this QR code. I'll also post it in the chat. You're welcome to share it with colleagues. This is a short online survey in the Survey Engine platform. It can be anonymous, or you can choose to give us your details if you want to be engaged more in the process. So this will be the first step of just streamlining what attributes and levels go into the discrete choice experiment. And then we'll again do an iterative set of focus group discussions with women living with HIV, and hopefully do the discrete choice experiment if our funding allows throughout the course of this year. So we're really excited about this piece of work. And with that, I just wanted to share some acknowledgements. This has been a long-term project, and I've certainly learned a lot through it, and it has not been done alone. So I just wanted to highlight our project team. If we'd been in person, Portia was going to be here in person, and Lou was going to be here in person, but they are on site at the moment. But really an amazing group of people who've been involved across the various aspects of this work. Collaborators, Landon and Lucia are my mentors here at UCT, and Suzanne, Maman, and Ben Chi at UNC are my US mentors, and Kate Klaus, Catherine Orrell, and many others been involved in the work. And obviously the health services who've just been incredibly supportive. There are people on this call who've been part of conversations around this from the time before I got funded to do it. So thank you for that. And obviously the health services and our funder, the NIH, who we're very grateful for, and hope they continue to fund this work. Very happy to take any questions. I think Landon had said that I will, hey Andrew, I should man the chat because it's easier for me to see what's going on. So if you have a question for myself or Mpumi, you're welcome to raise your hand or write in the chat. I'll try to keep an eye. I do currently have two screens, so I can see what's happening. Not seeing any hands or any comments. Ati, yeah, go for it.
Hi, Tammy. Thanks. Very interesting presentation. I was just wondering about the preferences with regard to the care model and the fact that there's a preference for integrated service. Do you think that has to do with the practicality of people having other healthcare needs, which is then done at, kind of in one appointment, or does it still have to do with the idea of some level of stigma if there's a separate infectious diseases section of the clinic and people still kind of being aware of that? Which of those kind of things are more, I guess you may not have asked it, but do you have any thoughts on why patients prefer that?
So I would say probably both aspects. So a lot of people did have comorbidities. So we're still in the process. We asked a bunch of other questions around both medical history and current medical conditions, including we asked about TB, hypertension, diabetes. And then we also asked other psychosocial questions around stigma. The ultimate plan is actually to do a latent class model where we can essentially group people into latent patterns of preferences and then see if there are other attitudinal or sociodemographic characteristics related to those preferences. So that's a plan, but we haven't got there yet. But I think it's probably both. So both the high levels of stigma reported still, and a lot of people with comorbidities. Although I can say from my experience with in the postpartum space, where we do have often integrated care for moms and babies, the practicalities are like work we've done previously. About 40% of moms and babies are attending different clinics anyway, even though our clinics do offer integrated maternal and child, many of our clinics offer integrated maternal and child health services. So there's a lot of things that go into the like logistics around that I think still requires some more understanding. And it will probably be a balance of both what can the services offer and then not like putting everybody into that box, because we think integrated maternal and child health is the way to go. But for some moms, that just might not work. And then how do we make sure her and her baby get everything they need, even if they want to attend different clinics, if that makes sense?
Yes, thanks. It does. Yeah, I was just thinking that's probably the hardest thing to address, even though it's a strong preference, because it depends on other things, and just understanding why the preferences may help with how you deal with it.
Yeah, and I think that's a good point. The preferences on their own are obviously not like, you could never just like go out and build an intervention based on what patients want, right? Because it's this balance, this overlap and balance on like what can the services do, what is feasible, what has the biggest like population impact, and then also trying to work into that people might want and need different things at different times. I think it is tricky.
Yeah, and I was thinking just if you would ask the service providers their preference, they would probably go in the other direction. Because, that differentiated care tend to give you a feeling of better quality of care if you're the care provider, but it's obviously not the patient's preference. So.
That's interesting. So I think we partly also why we're doing this more systematic stakeholder survey for the postpartum DCE is exactly that, and asking about the way the survey is structured is like for this planned attributes and level, like how would you rank it in terms of feasibility of implementing it and importance in terms of like how it might impact outcomes, to try to prioritize a bit better what goes into the ultimate list that people that patients get to respond to. Itu, I see your question around employment. So we haven't looked at it yet, but we do have those data, and I think it will be interesting. Also, like the mobile phone use stuff, I think is going to be interesting. Many more, there were more men who said they didn't have access to a phone. So that also changes like how they would be able to interact with different kinds of options. We didn't restrict it in the survey because we wanted to just ask everybody, like if you had access to this, but obviously those kinds of things would impact how people chose things. So still to look at. Hayley, yeah.
Hi, Tammy and
before we go to Hayley's one.
Sure.
I'm so sorry to jump in on Itu's one. quickly, just to say that, like Tammy said, we did ask people, why did you come back? And we haven't gone in and actually like looked at that data fully and categorized it. But anecdotally, from what I saw, actually being in the field and stuff like that, quite a few people did report that hunger was a big issue when taking the medication. And also you'll see it come out in some of the long-acting injectable questions. People actually being unable to, take their medication because, we actually just don't have food, and this stuff makes me sick. So or some of those reasonings did come through, but obviously this is very like anecdotal, what I'm saying, but yeah, it is a good observation, and it was something that was observed and would be really cool for us to report on going forward. And like Tammy said, there's in the beginning she showed this like whole big diagram, like it's your whole other real life before just disengaging in care. And I think that's really the underpinnings of this, and hopefully with the latent class as well, to say that what are all these different patterns and stuff like that. So thanks for the observation.
Thanks. When we go for it, Haley.
Hi, thanks. Thank you both so much. I think that this is so cool. I think you mentioned that you were able to essentially add random effects to each attribute in the experiment. And I don't know if you know off the top of your head, could you speak to if any attributes exhibited more heterogeneity than others potentially? And like which one, if you remember which ones there were.
So off the top of our head, no, but that's also because that's not really what we were looking for. It wasn't so much to interpret like the effect size of the random heterogeneity. It was more just for us to look at, does it exist? And it existing is what we're seeing actually real. Like, is this like heterogeneity significant, and stuff like that. But in terms of actually looking at where the biggest disparities, I guess, or where the most heterogeneity exists, we haven't looked at that specifically. But again, with the latent class, and even with interacting with gender, we also tried to look at, did the effect size reduce? So that was more so our, I guess, scope of interest.
Yeah, I think, no, perfect. And did you see that it was reduced with an interaction with gender?
I'd have to look at the spreadsheet again.
I remember us talking about this in Mpumelelo. I think it was, but it was still statistically significant. So the heterogeneity was not explained by just interacting with gender. And I think there are ways where we can report like the standard deviations to show like which attributes had more heterogeneity in choice, but we haven't done that yet.
Yeah, no, awesome. These findings are so cool.
We'll be knocking on your door, Haley, to help us with that.
Let's do a mixing class together. Let's go find determine where this random heterogeneity comes from. That would be awesome.
Yeah. I'm not seeing any other hands or any other questions. So if there aren't any other questions, then I think we can just say thank you so much for joining. I'm going to pop our advert in the chat for anybody who is a health provider or is willing to share with other health providers, and you might receive it through other networks. Landon, I see you've unmuted. I don't know if you want to say anything.
No, Tammy, I was just going to say thank you. Thanks to you and Mpumi for a great presentation, and thanks to everyone for engaging. This is exciting work, and so I was just going to do the vote of thanks.
Thank you, Landon. I see there was another hand that popped up and left. You're welcome to ask your question. Was it Marsha? Maybe it was a false hand. All right. Thanks very much, Landon, and for the opportunity to present. And you're welcome to contact either of us if you have any other questions.
Thank you, Tammy. Thank you, Mpumi. We're all clapping virtually.
Cheers, everyone.
Thank you, everyone.
Bye.
Thank you.
Bye.
Thank you. Bye.